Good morning, and welcome to the latest Facebook Live hosted by the National Cancer Institute. My name is Lisa Fuse, and I'm the patient advocate at the George Washington University Cancer Institute, and I am also a cancer survivor. I'll be today's moderator. Today we'll be talking about cancer survivorship and the critical role that research plays in understanding survivorship. I'm pleased to be joined by two experts in the field. Dr. Julia Roland, Director of the Office of Cancer Survivorship here at the National Cancer Institute, and Shelley Field, Chief Executive Officer of the National Coalition for Cancer Survivorship. Before we begin, I'd like to tell you a little bit about myself. My life changed when, at the age of 25, I was diagnosed with breast cancer. Although this was shocking, I was very fortunate to have excellent doctors and a great support system of family and friends. I had a modified radical mastectomy and 6 months of chemotherapy. Toward the end of my treatment, I decided to go to law school with the hope of someday working with other cancer patients. Shortly after, second primary breast cancer and underwent the same treatment and chemotherapy. This happened several years before the identification of the BRCA1 gene mutations. But when testing was available, I was tested and discovered that I am BRCA1 positive. At about the same time, my husband and I discussed the possibility of having children. And because my cancers were both hormone receptor negative, my doctors gave us the go-ahead. We now have two beautiful daughters who are 18 and 21. Who will both have to grapple in the future with decisions around genetic testing for themselves. As far as professionally, I am the patient advocate at the George Washington University Cancer Center with responsibility for bringing the survivor's perspective to our work. And I'm thrilled to work with a team of people who are passionate and committed to advancing the science of survivorship and improving the quality of life for survivors. And now let's have Julia and Shelley tell you a little bit about themselves. Julia?
Thank you, Lisa, for sharing your story with us this morning and for being our moderator. So it's a pleasure to be here on this Facebook Live activity this morning. Again, I'm Julia Roland, and I direct the Office of Cancer Survivorship at the National Cancer Institute. I come to this role by a slightly wandering background. I started out in the field as a developmental psychology expert in a doctoral program. And along the way, I became interested in what happens to people when they're ill across different points of the life trajectory. And in the course of that, I became fascinated by the literature on the psychosocial and behavioral responses of individuals who were diagnosed with cancer. So after I received my doctorate degree, I went down to Memorial Sloan Kettering and took a fellowship in psycho-oncology, then a very nascent field. While there, I had joint appointments in the Department of Neurology and in pediatrics. And before leaving Memorial Sloan Kettering, I had the opportunity to create what turns out was probably the first survivorship program in a comprehensive cancer center in the U.S. The program offered a variety of educational programs and non-medical services to individuals who were finishing treatment who were adults at the time of the post-treatment experience. When my family moved to Washington, D.C., I took a job at Georgetown University Medical Center and the Lombardi Cancer Center, and there set up their psycho-oncology program before being recruited up to the National Institutes of Health to the position I now hold at the National Cancer Institute.
Thanks, Julia. I'm Shelley Field, and I have the privilege and honor of leading the National Coalition for Cancer Survivorship. We're a patient advocacy organization dedicated to improving cancer care for all people touched by cancer from the moment of diagnosis. And we do that through public policy advocacy and representing the voice of patients and survivors in discussions about policy that affect them here in Washington, D.C. We were founded in 1986 by a group of people who got together to talk about their post-cancer experience. And they decided to change the lexicon from cancer victim to cancer survivor and really begin the conversation about what it means to live well after a cancer diagnosis. And they decided to move the organization here to the DC area because they knew that focusing on public policy was an important way of advancing the conversation about survivorship in hopes of helping people to live well after cancer.
Thank you. We invite your on-topic questions during this Facebook event. As you have questions, please ask them in the comments section, and we'll try to answer them as time permits toward the end of the event. Okay, let's get started. The first topic we'll talk about is what it means to be a cancer survivor, which I'll address first. And my perspective is that cancer survivorship, really being a survivor, is defined by commonalities and differences. We all walk through our cancer experience differently due to a host of factors: your diagnosis, your age, your socioeconomic background. At the same time, we all have things in common. A devastating diagnosis that we didn't expect, treatment, and changing plans and expectations. In all cases, I think cancer profoundly affects the path that your life takes. In my case, it affected my education, job, and volunteer activities. One thing I think that cancer survivors have in common, though, is that we all benefit from the great research done by institutions such as the NCI, National Cancer Institute, the National Coalition for Cancer Survivorship, and GW Cancer Center. Shelley?
So when I mentioned that our founders really changed the lexicon because people were considered victims, and they didn't want to be called victims, they wanted to be called survivors. And that was 30 years ago, and today there's a lot of discussion about the term survivor, the concept of being a survivor. And I hear from people who that word doesn't resonate with them. They don't feel like a survivor. Sometimes it's because their treatment was so minimal that they don't feel like they deserve the title of survivor. Sometimes it's because they know that they'll be in treatment for the rest of their lives and they're not going to finish treatment and they don't want to consider themselves a survivor. Sometimes they're just other words that resonate better with them to define their own experience. And I think that people should define their experience however it makes the most sense to them and what feels right to them. We use the term survivor and we define it from the moment of diagnosis. You don't have to have completed treatment to be considered a survivor. Once you've had that diagnosis, your life has changed. And our founders also expanded that definition to include the family and friends who are taking care of a cancer survivor and living through that experience with them. So when we are advocating on behalf of cancer survivors, we're advocating on behalf of everyone who's had a cancer diagnosis or is touched by it, no matter what you want to call yourself and how you personally identify. I know there's a lot of discussion about other words we could use. I'm not sure we'll ever come to agreement on a word that fits everybody's experience. And I think that, as Lisa pointed out, it's different for everyone, and everyone should identify themselves the way it works for them. But we will continue representing people who've had that cancer diagnosis, no matter what you want to call yourself. And we're trying to be your voice here in the policy arena here in Washington, D.C.
So I want to thank Shelley for talking a little bit about the history of the term survivor as we consider it today. When the intrepid group of 24 individuals got together in Albuquerque, New Mexico, and founded what we now know as the National Coalition for Cancer Survivorship, that was back in 1986, what they realized was, at that point in time, individuals diagnosed with cancer, at least 50% or more of them were going to be here in 5 years. However, the medical definition of a survivor was someone who had been diagnosed with cancer, treated, and remained disease-free for 5 years. And they said, that's really not acceptable. We can't put your life on hold for 5 years and then decide you can resume living. So they said, we need to change the definition. And so we will consider an individual a survivor from day one, from the time of diagnosis, for the balance of that individual's life. Important points about that decision. They never, ever meant it to be a label. They didn't mean for people to say, I have to call myself a survivor, because we know many, many people are not at all comfortable with that. But they did want to do two things. Actually three. They wanted to get rid of the victim language, that you are not a victim. You have a role in this. It's important to be active in your own care. That was a very important message to convey. But more importantly, they wanted to send a message of hope. There is life, and rich and meaningful and full life after a cancer diagnosis. And most importantly, they wanted to change the conversation. They wanted patients and their families and their healthcare providers, their practitioners, to be thinking about what's life going to be like after cancer and making decisions with that in mind. And I would have to say today, when we look back 30 years later, that dialogue is different. I think survivors and their healthcare providers and their families can bring their concerns to the experience and say, this is what's important to me, this is how I wanted to be treated, this is what I'm hoping for. So I think that's very important. I did want to mention one other slightly different definition, and that's the term we talk about, survivorship research. So the NCI, we embrace the advocacy's definition of survivor, but we define survivorship research slightly differently. While we know that what you do following your diagnosis is going to affect outcomes later, we think of the research in that area as looking at people post-treatment. What happens after your definitive therapy is only? You may be on some maintenance therapies, but we want to know what happens to that big majority of people who are actually post-treatment, simply living with this history. And that's really what the Office of Survivorship was created to do at the NCI, is to bring attention to a deficit in our knowledge in that, and to promote and support research looking at those issues.
Okay, thank you. Well, I think you've actually both touched on what our next issue is what have we seen change in the area of survivorship?
Well, I'll start, and Julie and I were both at a meeting that the National Cancer Policy Forum hosted earlier this week, talking about long-term care and survivorship. And really, we were looking at how have things changed in survivorship since the report released by the Institute of Medicine in 2005 called Lost in Transition, that really outlined where are the gaps for people once they finish treatment, and cancer survivors feeling lost, like they're done with treatment and now they're back into trying to create their new life after cancer treatment and deal with the side effects and symptoms and psychosocial issues, educational issues, employment issues, financial issues. And so the Institute of Medicine put out a report with a lot of recommendations about what we needed to do to improve. And at this workshop over the last 2 days, we talked about where we've come and where we still need to go. It was clear we've made progress in some areas. As an advocate, I don't think we've made enough progress. I think one of the first speakers, Dr. Niraj Arora, said that we should leave frustrated and wanting to act. And I felt frustrated because there were a lot of things that we know and we're not doing. And how can we make sure that we are doing the things that we know work to try to help cancer survivors? But we have come a good way in terms of, I think people really understand that survivorship is important and that cancer doesn't end when you stop treatment, and that we need to do a better job of helping people medically, psychosocially, and in other ways to manage their life after, and to get back to the kind of life that they had before, or whatever that the quality of life that they will have going forward after their cancer treatment. So I think that there's a lot of work to be done still, even though we have had some improvement, and we were able to talk about that over the last few days, and there's still more work to be done.
There is, and it was a very powerful meeting, and actually you can go to the National Academies, that was webcast, so if you're interested in those proceedings, those are actually available. And I think one of the important take-home messages, certainly for me, was the words of our very, very articulate advocates who were there. So I look at Lisa and I look at Shelley, who were so important in moving the ball here. Moving the needle is what we kept talking about at this meeting. And one of our advocates, Meg Gaines, who talked about nothing about me without me. And that's a core thing. So much of what we've learned in survivorship is really from the time that individuals have taken to spend with the research community to talk about their experience and to participate in studies trying to improve that outcomes. And I would say the three big things that have changed in the last couple of decades in survivorship is, first and foremost, we recognize it's a unique part of the care trajectory, that it's different than being in an active treatment. It's different than if you have advanced disease. That period post-treatment, which a lot of people feel is this black hole. You do all of these things, you're released, you're grateful, it's wonderful, and then what? Now what happens? That's that area of science, and it has a place now in what we call the cancer control continuum. So you have prevention and diagnosis and treatment, survivorship, and then end of life, whether it's from cancer or something else. Very important. Second dramatic lesson was, and again from our survivor community, it's not over when it's over. What we've learned in the last couple of decades is that cancer and its treatment can have persistent effects for individuals on every domain: physical, psychological, social, economic, existential. Some people have a lot of problems with their treatment results. Some people have very few. And as the scientific community, we don't quite know yet who's at really high risk for these. Can we identify them early and prevent those from happening, or improve an outcome? If we can't prevent it from occurring, can we minimize its effect? Very, very important. And the final is, you got to be planning for treatment. So you can't just put this all on hold and not think about it. That's something, planning for care and survivorship is very important.
Thank you. So why do we do research on survivors, and what are some of the important findings that have been made in this area?
Oh boy, she's looking at me. Okay, this is the hardest task I have. I mean, we talked about the fact that we would ask this question is, what is some of the research here? And for me, I get very excited because we are actually supporting here at the Cancer Institute an amazing number of studies looking at this science. If I look back when I first took this position in 1999, there were about 9 studies in that, what I described before as that survivorship period. Now we have over 215, funded not just by the Cancer Institute, but also Institute of Aging, Nursing Research, Heart, Lung, and Blood. Very exciting horizon ahead of us. And when I think of some of the findings, so one of the wonderful things we do is we do fund survivor cohorts. Probably our oldest cohort established back in, I'm trying to think when I want to say it was back in 1994. So our childhood cancer survivor study, which includes now some 36,000 individuals who were treated as children or adolescents, originally diagnosed as children or adolescents, who were recruited to the study when they had met their 5-year mark. And we have about 5,000 of their siblings in this study, and this allows us to look at long-term and late effects in this vanguard of our survivorship movement, if you will, our youngest survivors. And we had data published last year that showed us that our new treatments, so children treated in the 70s versus children treated in the 90s, these children in the 90s have fewer second cancers, fewer serious comorbid conditions as a function of their cancer and treatment. That's very exciting to realize that changes being made are having an effect, because very early on in childhood cancer we realized cure is not enough. We have to be looking at those long outcomes. We now have some very cool science looking at what can we do about fatigue, very common persistent effect after cancer. We have researchers up at the University of Rochester, Karen Mustian in particular, has just done a meta-analysis with colleagues showing that when you look at the different interventions available, that cognitive therapies or psychological therapies and exercise can be very beneficial for managing fatigue. Drugs, not so much. But that's hopeful because these are things that most people can do, is becoming active. Her work in particular has looked at the role of yoga in helping manage fatigue. And that brings me to the last area, which I think is very hot, moving fast, and that's health behaviors after cancer. So we know from a large study of some 3,700 colorectal cancer survivors that those individuals who increased their leisure time physical activity, so you're not a couch potato, get up and move about, decreased their television watching, had longer survival. That's exciting. And right now we have a trial that we're running among women treated for early stage breast cancer who are overweight to see if a weight loss program, so physical activity and calorie reduction, will alter recurrence patterns. So very excited science. Stay tuned.
So I'd just like to throw out too that I was excited to be part of a working group last year during the Cancer Moonshot that looked at what can we do. The Cancer Moonshot overall was looking at what can we do to accelerate progress in cancer research. And one of the proposals from our working group was to really look at symptom management research. And I think the reason I was excited about this is because all these studies you're talking about are very important to people's quality of life. But sometimes they just take a little bit of a back burner to the exciting, treatment saving people's lives research. And we think that this stuff is really important because it's how you live your life. So I knew that when the moonshot was launched that the focus would be on a lot of exciting technologies, and would we get anything in the moonshot that really addressed people's quality of life. And I was very pleased that the Blue Ribbon Panel report included one of our recommendations on symptom management. And it's really about looking at the symptoms during treatment and afterward, because the symptoms can last throughout after treatment is over. So that is something that the NCI is working to implement, and I don't know if you can tell us a little bit about what they're doing. I was just very pleased from a survivorship standpoint that was included as a major point of focus for the Blue Ribbon Panel and the Moonshot Initiative.
We are definitely excited about that too. And so the Blue Ribbon Panel put that together with one of the 10 recommendations is look at symptom management, and we just had a couple of initiatives presented to our Board of Scientific Advisors who approved these to move forward for funding opportunities that are going to look at how do we better systematically assess and intervene with the more prominent symptoms that we're seeing affect our survivor population, and also measurement strategies, standard tools that we can look at for toxicity assessment. So as someone's going through treatment, these are going to be initiatives, funding of initiatives, stay tuned, coming out this fall. If you want to know more about what the NCI is doing on the Cancer Moonshot, go to cancer.gov, and on our landing page you'll see a whole section on Moonshot. You can click on that and see all the different array of things we're doing, but we're not neglecting patients as part of this, and that's a very important point that Shelley's making.
All right, thank you. So if you're just joining us, I'm Lisa Fuse from the George Washington University Cancer Center, here with Dr. Julia Roland, the Director of the Office of Cancer Survivorship here at the National Cancer Institute, and Shelley Field, Chief Executive Officer of the National Coalition for Cancer Survivorship. So we just started a little bit to talk about our next topic, which is what's next in cancer survivorship and what's important for us to be looking at right now.
Shall I start that? Would
yes,
you like
you
me
can
to
start that.
pick up that one again? As the designated lead in this office, and that's really, as I say, it's really been a privilege for me to be in that position. One of the things we know about survivorship science is our bread and butter is always going to be looking at the long-term and late effects, particularly as we recognize treatments are changing. So we now have immunotherapies that we didn't have before. We have precision medicine and targeted therapies, and we know that, at least in my experience, there has never been entirely benign therapy. We know that these are going to have some kind of toxicities for patients. The question is, what are they, who's at risk, and how do we prevent or manage them? So bread and butter science is always going to be there. But some of the newer topics, and you heard Shelley talk a little bit about this, is what's the care going to look like for this growing population? We have 15.5 million individuals in the United States alone with this history, most of whom are post-treatment. How are we going to care for them? Who's going to follow them? Who's going to look after Lisa's well-being and as she moves forward? Should it be your primary care physician? Is it her oncologist? Is it a combination of those? What kinds of tests need to be done? What can we be encouraging her to do to ensure that she will have a long and full life ahead of her? So big question there is care delivery models. How are we going to assess those? Can we come up with some practical ways that we can make sure that it's effective, equitable, accessible, affordable for individuals who are carrying that history? Another big area, as you heard me mention, is looking at the economic impact. So this sort of financial toxicity is kind of a new, interesting challenge for many individuals as our therapies have become more expensive. What's this doing to individuals and their families post-treatment? But the biggest thing for me, again, I'm a developmental psychologist, so I'm interested in life course trajectory here. One of the realities is the growth in the number of survivors across the country in the next 2 decades is actually going to be driven by the aging of the population. Right now, about 63% of that 15.5 million are age 65 or older, and that proportion is only going to grow with time. Despite this, our portfolio of science has very limited number of studies in this older adult population. Big gap in our research area that we clearly need to fill. A couple of other things I just want to talk about also or mention is growing interest in caregivers. What's the burden on family, and how can we better support those individuals who are our secondary survivors? Under that original definition, they're included in the survivor population. and also health promotion, as you heard me say. What can we be doing that individuals can do themselves or do with their families that can really alter outcomes? So again, a number of topics I think are moving forward that we're excited about.
Super. Thank you.
I don't have anything to add.
Okay, thank you. And then finally, what is it important for a patient to know about survivorship? Wow. Or about survivorship research?
What would you tell a patient?
I think, again, it's individual to a patient. For myself personally, I always had a great interest in knowing as much as I could. I felt part of my taking control of my cancer diagnosis and treatment was having the most information possible at my fingertips. I wouldn't prescribe that for everyone, though, because I know that not everyone has that same interest. So for most survivors, I would say learn as much as you can and stay current, because as you mentioned, the treatments continue to change.
That's great. I'll let you.
Well, I think what's important is there's life after survivorship, after cancer. Survivorship is an important thing to be thinking about right from the beginning. And that survivors have an important role to play in their health and well-being after treatment. Engaging in that, finding out what's going to be best for your recovery, what's going to be important for you. What do you need to know about your cancer treatment that may put you at risk later? So this whole notion and a movement across the country now on individuals asking as they finish their treatment, make that transition to recovery for survivorship care plans has a lot of merit to it. And you're going to hear a lot of conversation about that among the survivor community and in the healthcare delivery community, oncology community, because this is now a requirement for some of the certified centers, the Commission on Cancer certified centers, that they make sure that individuals who are treated in their centers receive a survivorship care plan. Survivorship care plan has two components to it. It is a treatment summary, so you know what all of your cancer characteristics were, tumor markers, if that's important, all the treatments you would have received as part of any complications you had. Very important history to have so that we know if we find late effects attached to a history of a particular kind of treatment later, we can alert you about that and you'll know about it. But the second piece of that is the care plan. Together, that makes your survivorship care plan. The care plan is going to talk about four main things. What should be the surveillance for your cancer? What do you need to be doing to see if it's come back or if you have a risk for second cancer? The second is screening for problems you may have now. We talked about persistent effects. You may have fatigue, sexual dysfunction, memory problems that we need to intervene to address. Prevention of late effects, so might be a health promotion. What could you be doing? Changes in lifestyle or behavior that would benefit you. Chemoprevention as that becomes available. And the fourth important part is communication. Who's responsible for what, including what's your role in your own care, but who's going to do what. And I really want to make a big pitch here. It's not about a piece of paper, so it's not, congratulations, you're a survivor, you're done. It's about the conversation. Again, that's what's really critical in this. It's a process, it's a dialogue that survivors and their families need to have with their healthcare providers about what's next, what's the role, how we're going to move forward.
And I would add to that that if you don't get one from your providers, you should ask for one as a survivor and ask for, say, I'd like to have a survivorship care plan. I need to understand what my treatments have been so that I can communicate with other providers, and I need to talk with you about kind of planning for going forward. I think that there's a lot of movement towards creating them, but it is, most times when I talk to somebody and ask them, did they receive a survivorship care plan, the answer is no. So I think that until patients really demand it, it's not going to happen. And unfortunately, patients are really caught in the situation where they're the one who have to be the quarterback of their care. So if you come up with a side effect or that may be a cardiac issue, then you go to see a cardiologist, or you may see a neurologist or different types of specialists. And we don't do a very good job of coordinating that care among specialists, and unfortunately that burden often falls to the patient and family. And having this, when you go to the cardiologist, to be able to say exactly what your treatment was will be helpful in going forward and addressing issues that you may have. So I think it's really important for patients to ask for it. And then it's also something that we at NCCS have advocated for the adoption of in practice. And one of the ways we've advocated for that is to try to make sure that there's payment for it, because it is a burden on the medical institutions to create it, and if they're not adequately reimbursed for it, it makes it harder for them to do it. So that's something that we've advocated on behalf of.
Out of curiosity, you have a survivorship care plan?
I do not. My last diagnosis was in 1990, long before the words survivorship care plan were ever strung together in a sentence. Yes.
Right.
Yeah.
Something to think about.
Yeah.
Well,
absolutely.
and also, I mean, there are ways for survivors to create their own.
Absolutely.
And we've partnered with a number of other organizations on Journey Forward, which is a tool that helps providers create survivorship care plans. But there's also a piece of Journey Forward that allows a survivor to create their own. You're obviously not going to have access to all of the information, but it helps give you the framework and structure and at least the questions to ask if you want to go back to your providers, and so that you can fill in the gaps for what was important in your treatment that you need to know going forward to communicate with your other providers.
And as I recall, Shelley, the URL for that is journeyforward.org,
Yes,
right?
that's
So
correct.
you can go and look at that and see what should go into it, get you thinking about what information would be helpful to you and what kind of conversation you might want to have if you're a survivor yourself or you have a loved one who's a survivor about care going forward.
Terrific. Thank you. So now we'll turn our attention to questions from our viewers. The first question that we've got: there are a lot of psychological effects that a survivor deals with, especially once treatment is over, but many doctors don't seem to address those. Why is this, and what research can be done to help address this?
Gosh, that's a great question, and actually it was one of the hot topics at this Institute of Medicine, now the National Academy's two-day meeting that Shelley referred to earlier about the long-term care of cancer survivors. We know that for many, many people, perhaps for most survivors, at some point in their trajectory, they will have psychological issues, social issues that come up as a consequence of their diagnosis and treatment. And we know that this is a very important part of recovery. In fact, it's so important that the Commission on Cancer that I referenced before, that's a credentialing body for big centers that see a lot of patients, have now made it a criteria that individuals treated for cancer are screened for what they call distress or psychological well-being. So we at least have a quality indicator saying this is an important part of quality cancer care delivery, but it's not enough often. So you can screen, but the real question is, what are we doing about it? And I think that this is a question that advocacy needs to keep coming back to, because we do have challenges in meeting those psychosocial needs. We have another, again, Institute of Medicine report that said just that, is, cancer care for the whole patient, meeting psychosocial health needs, telling us that we're falling down at this and that we need to do a much better job. One of the challenges I'll say we do have out there is that we live in a culture where mental health is often relegated to second place. And as Shelley was saying, important in accessing care is, can you get it covered? Do I have health insurance or some policy that will cover this? And then do I have practitioners or someone who can help me with this in my community that I can avail myself of? So very important question. Keep asking that, because I think can change the landscape about delivering psychosocial support to individuals who've been treated for cancer.
Thank you. Thanks. That's great.
Okay, the next question is, as a cancer survivor, how do you still be your own advocate, yet not worry about every pain or discomfort thinking it's cancer? I can certainly relate to that question, because often that is the very first thing that crosses your mind. Personally, I think one of the best things you can do is have a trusting relationship with your doctor, whether it's your oncologist or whomever your quarterback doctor is, where you can discuss the concerns as they come up. And I think over time, the farther you're removed from your cancer treatment and diagnosis, I think the easier it gets sometimes to think through and know that it's probably the same kind of ache or pain that any other person has. But do you all have thoughts on that?
I think that's really good advice. And one of the things you said before was that you've lived longer, more of your life as a cancer survivor than before. And so I think you have that long-term experience. It's helpful to know that it gets better, but I do think it's very common in what we hear that you worry about everything. And I think having that trusted relationship with a provider that you can talk to is probably the most important thing. What about from a psychosocial
Yeah, and
standpoint?
I would say one thing that we're reminded of in this conversation, this question, is that fear of recurrence is probably the most common long-term effect of having had cancer and cancer treatments, and probably affects pretty much every individual who's diagnosed. Some people worry much more that their cancer is going to come back. Some people seem not to worry very much about it. It tends to get better with time. But if it's the case, you're a survivor and you find yourself constantly thinking about this, it's a good idea to talk to somebody about it and say, you should be able to park this somewhere. I think it's unrealistic to believe you can make it go away forever and not ever think about it. That's normal to have thoughts about it, particularly around follow-up visits, or if somebody else is diagnosed, it's going to remind you of your own experience. But if you find you're thinking about it all the time, that's not typical, and that is something that should be discussed with your providers, with perhaps another survivor who can say, yes, I understand that, here's how I manage it. Maybe it means taking some stress management, relaxation, being more active, getting out, finding ways to distract yourself and remind yourself you're here and now and well.
Thank you. Great advice from both of you. Our next question is, what projects are going on at the George Washington University Cancer Center in this space? So the GW Cancer Center is conducting survivorship research on a number of different fronts. For example, GATE, or Generation and Translation of Evidence, of which Julia is a part, is a cancer community of practice with a focus on survivorship. GATE encourages collaboration among survivors, caregivers, researchers, and providers to disseminate patient-centered outcomes research more quickly. And if you'd like to take a look at our website, it's cancergate.org, and it features a number of findings and resources related to survivorship. We've also conducted research to better understand how survivorship care is accomplished in healthcare settings. The Survivorship Care Plan Provider Survey was the largest national survey to date to document how survivorship care plans are implemented in practice. We found that SCP implementation is tremendously varied and that providers are struggling to meet Commission on Cancer Accreditation Standard 3.3. In the Evaluating Survivorship Care Model study, we worked with more than 900 cancer survivors in 32 cancer centers across the U.S., with data collection occurring multiple times over 6 months. And we're still finalizing those results, but look forward to sharing them as soon as they're available. And finally, we're working with states that have received awards from the Centers for Disease Control and Prevention to focus on survivorship. We're providing training to states and working with them to raise awareness among providers about the needs of survivors and for survivorship care through our e-learning series, which is available on our website. So thank you for that question. Next, what are the concrete things we can implement right now to help survivors in their long role as a survivor? Is it education? What about survivorship care plans? How do we help implement survivorship care plans in community oncology settings? Well, we've started to touch on all of these things already. Do you have additional thoughts right off the bat?
Well, yeah, there's one thing that I could add. So NCCS has a program called our Cancer Policy and Advocacy Team, or CPAT, and it is a program where we engage advocates from around the country to work on policy and advocacy both at the local level and at the national level. So we had a symposium in June here in Washington, D.C., and Lisa attended it, and we had a day and a half of training on various different issues related to cancer policy and survivorship, and also skills building about how to tell your story, how to meet with a legislator, a member of Congress. And we also had workshops on improving survivorship care at the local community and on improving doctor-patient communications. And we ended with a Hill Day where we went to meet with our members of Congress about important issues related to access to quality, affordable health insurance. So one of the things that we work on in the CPAP program is improving survivorship care at the local level and empowering advocates to understand how they can go work with their cancer center to try to provide a patient perspective on what needs to be done to improve survivorship care. And we are building that capacity over the next year to really do a better job of providing that assistance and empowering and support for advocates to do that. What you said, Meg said, nothing about us without us. And we've done a really good job in over the last number of years in engaging patient advocates in the design of clinical trials, in a lot of aspects of care to make sure that the patient perspective is included. And we want to make sure that's also that patients are included in the design of the care delivery. And so we're trying to help patients to be prepared to do that and educated and knowledgeable, and then also help support them in their roles as they actually do that at the local level.
And I think this whole notion of, think global but act local, starting in your own backyard. So if you were treated in a particular setting, is saying what's happening in that setting, reaching out and saying what would be valuable for survivors to know. This survey that was done by GW among practitioners to say what are the challenges they face and what do we need to do to implement care plans as moving forward. I think this is going to be a fast-moving area in the next couple of years. People are really paying attention to this, but most importantly, we want to know that care plans make a difference. If it turns out that the way we're delivering them has no impact at all, we shouldn't be delivering them that way. And that to me, as a scientist, I want to know what's the best way to communicate about life after cancer to all the different constituents, for oncologists to know what are the late effects, for primary care, and how do I manage someone in my practice who happens to have a cancer history, for a survivor, what do I need to be doing, for family members, what's my role in here, is making sure that everybody is on board with this and what's important to them and how do we reach each of those entities.
And I just want to add, because I think what you said about then we shouldn't be delivering it that way, like how we deliver the care plans is really important, because I think there's been quite a bit of pushback on why are we doing this if we don't know that it helps with outcomes. Well, if you just hand somebody a piece of paper and never mention it again and don't do anything to help them coordinate the care, it might not actually improve outcomes. So I think we have to be, instead of saying maybe we shouldn't be doing this, we should be looking at how do we do this better? How do we deliver care plans in a way that it is not just a piece of paper, but it is actually a conversation about what needs to happen to help this individual get back to the kind of, and maintain the kind of quality of life that they would like to have, and through managing their symptoms and managing their side effects going forward.
Mm-hmm. Absolutely. And hopefully the GW study will help answer some of those questions. Mm-hmm. For someone who's a survivor and wants to take a concrete step today, I would refer back to the survivorship care plan that's available at Journey Forward. You can go online, fill that out, and have it in your hand the next time you visit your doctor. And it is an evolving document. Once it's finished, you can always make changes as your treatment changes, or if you do experience new side effects, all of that can continue to be woven into that document. So that's a very useful thing to have. We have a question asking if you can comment on the role of rehabilitation specialists in survivorship care.
I would love for you to, Julia, unless you...
Did you see any rehab specialists as part of your care?
I didn't, although interestingly, speaking of late effects, I have recently, almost 30 years out, begun to see physical therapists and massage therapists. The reconstruction that I had employed a technique, I don't believe it's done anymore, a latissimus flap, where part of my latissimus muscle was tunneled under my arm and anchored in the breast area. And those muscles over 30 years have tightened extensively, and the physical therapy and massage has been extremely useful even this many years after my treatment. So
I think that's a great question, rehab, and I think we're more and more hearing that that conversation raised, saying as people are finishing treatment, we need to do some kind of assessment on their functional well-being and what their capacities are and areas that might benefit from a rehabilitative intervention. You know, it's interesting, in the United States, we used to have quite a big focus on rehabilitation when we did much more extensive surgeries, so radical mastectomies, much more uniform use of colostomies, amputations were much more extensive, so our patients really needed this. And what's fascinating is the surgery has backed off, become more conservative, if you will, of tissue. We have fewer people being referred to rehab, even though that might be incredibly appropriate. We don't see the same trends in Europe or Canada even. Actually, there's much more focus on rehab. So it is a topic that I think is very timely and that is being reconsidered now as we think about, if I'm going to suggest that a survivor go and engage in physical activity, is that person fit enough to do that? Do I need to get them up at a level where they actually benefit from a routine habit of exercise? Or do I need to make sure they're not going to further injure themselves or cause further dysfunction without the rehabilitation? So again, great topic to bring up. I think is one we're going to see discussed more openly as we look to the future.
Okay, thank you. Can I ask a question about it, though? Are there people who specialize in cancer rehabilitation, or could any rehabilitation specialist help someone who has issues where they need that kind of service?
That's a great question. As not a rehab expert, I'm not a physiatrist, but you'd want to ask someone like that. But what is the case is there is now a certification board for rehabilitation facilities that has a cancer module. So you can actually certify up in care of individuals who have a cancer history. So that is interesting. But I would say many centers don't have that or don't have personnel who are certified in that. But that doesn't mean you can't take care of someone with a cancer history. Mm-hmm. So I think someone who is very well trained in rehabilitative medicine could do that. I mean, you would probably want to encourage assessment by someone who has experience working in a cancer setting by preference, but that may not be someone who's in your community. So again, I think we're going to see some more attention brought to this about what kind of training do individuals need to have to do this, and if we're going to apply it more generally, what needs to be available.
Thanks. Well, I see we have time for one more question, and the question is, what about caregivers? Are there studies on the effects of cancer treatment on them, and where can they go for help?
Love that question.
Yes, it's a really
caregivers, another one of our big areas that we've opened. So the National Cancer Institute is very, very interested in this, actually in partnership with our colleagues at the National Institute of Nursing Research, or NINR. In fact, NINR in the beginning of August is going to have a meeting on caregiver science to say how are we going to advance this field. We have funding announcements at the NCI on promoting the science to look at how are our caregivers doing and how can we intervene either in the caregiver and or their care recipient to make sure the health of both is improved and look at their healthcare utilization as a consequence of those interventions. So we're very interested in this. If you think there are 15.5 million survivors in the United States, probably about an equal number of caregivers, so that's a large number. We have surveys that are looking at the burden of that, and we know that many caregivers themselves may be older, so it may be spouses taking care of their loved one, or adult children who are now sandwiched, as you say, taking care of their children plus an older adult or parent. In here, we know that often they feel that they're not informed about how to be helpful in delivering the care they're being asked to deliver. They're neglecting their own health. So there are lots of issues for our caregivers that we think it's very important to address, because we do know that if a caregiver does well, he or she is going to be better able to provide support to someone going through and recovering from a cancer treatment. And that dyad, it's mutual. So if the patient's doing poorly, often their partner is doing poorly, and we want to say, what can we be doing to maximize outcomes for everybody involved? So again, more research coming on that, an important topic and a great question to ask.
I'm glad to hear about these funding opportunities, just because I think caregivers have not received sort of the attention that they need to, and it is really, I think that also as we shift more of the care to an outpatient setting, there's more burden on caregivers. I mean, when someone had much of their treatment in the hospital, there were people there to care for them, and when most of your care is not in the hospital, that puts a lot more burden on people in your family to help you, and I think there's also a burden on the patient knowing what their caregiver is doing for them. I mean, and so I think it's a really important issue, so I'm glad to hear about some of the research that's being done.
Much longer care, outpatient care, much more complex regimens, multimodal, so surgery, radiation, chemotherapy, hormonal therapy, maybe biologics, a lot of oral medication use, so family may be expected to help monitor toxicities or adverse response when the patient goes home. And then post-treatment, much longer follow-up. And I think what many caregivers don't realize, family at large don't realize, is recovery takes time. They're expecting their loved one to finish treatment, great, you're going to be back, pick up all the things you were doing before. It doesn't work that way. And so recognizing that there is this period of recovery that may take as much and sometimes perhaps even longer than the original treatment, it's very important for them to be aware of that and get support to help manage that going forward.
Okay, thank you. Well, that's all the time we have today for questions. I'd like to thank all of you who've taken the time to watch this latest Facebook Live from the National Cancer Institute about the role of research in cancer survivorship. Julia, Shelley, do you have any last comments you'd like to add?
Again, what a privilege to have these two outstanding spokespersons for survivorship science. And I would just say that the Office of Cancer Survivorship would not exist without advocacy. So we are very indebted to the advocacy community for bringing attention to the fact that we need to be looking beyond cure and looking at the health and well-being of all survivors. If you want more information about all the work that we're doing in this, I'm going to give you two places you can reach out to. Our Cancer Information Service, and that's 1-800-4-CANCER or 1-800-422-6237. You can get live help at livehelp.cancer.gov, or you can go to cancer.gov, type in Office of Cancer Survivorship, and see everything that your office is doing, hopefully on your behalf.
Thank you. We're really grateful to you, Julia, for your leadership in the Office of Cancer Survivorship, because it is so important to advance the science to help people live better after cancer. And you can also go to canceradvocacy.org to learn more about the National Coalition for Cancer Survivorship and our CPAP program, which empowers advocates, and of which Lisa is a wonderful member. And so we're grateful to you, and thank you for moderating. You did a great
pleasure.
job.
Thank you.
I echo thanks right back at both of you for all the work you and your institutions are doing. And I want to let our viewers know that this video will continue to reside on the National Cancer Institute's Facebook page, and it will soon be available on the NCI's YouTube page as well. Thank you.